Hi, welcome to our podcast, DIL, or Digital Health Innovations for Long Life. We have with us Dr. Nandakishore, who I know him for a very long time, almost 10-15 years. He is an anthropologist and also works at University of Hyderabad as an associate professor. We keep hearing about the terms human-centric healthcare, usability, service design, and qualitative research several times in the digital transformation of healthcare. I think these are new to a lot of us, and we have an expert here who will explain a little bit in detail how these things can be applied to the new emerging areas in digital health. But first we need to know about the expert. So let's start asking him when and where he was born, and perhaps slowly build his life alongside. Dr. Nandu, can you please tell us when and where you are born?
Thank you, Dr. Suresh. It's a pleasure to be speaking to you about myself and the potential of anthropology and qualitative research in digital health. So, I'm born in Warangal in 1975 in the month of August. And Warangal being the place which is known for its ideas of resistance, ideas of equity, people, and that actually shaped me in terms of my ideas around human centeredness in a very early stage. Essentially, we say that the place shapes us, place we are born, place we are raised, and that's something which happened with me. Warangal being a place of certain qualities have shaped my ideas about what I should be doing.
So, what next? Where did you go to school? And
Yeah, so I've done my schooling largely in Hanamkonda. It's a part of Warangal district. It's a city, it's a town, a small town. But that also has been a center of education. It had schools, both public and private schools, and also public and private technology institutions, like such as those days these engineering colleges called regional engineering colleges, which are popularly known as NITs now. And there was Kakatiya University, which was a university which offers a broad spectrum of courses in all disciplines. And also we had Kakatiya Medical College. So I studied my schooling. I did my schooling in a school called St. Peter's High School, which was sort of an English medium private school, and later moved on to pursuing my graduation in botany, zoology, and chemistry, and that was in Government Arts and Science College, which was affiliated to Warangal Kakatiya University in Warangal. So that's my academic journey.
so I'm assuming you would have at least visited a lot of touristy places around Warangal area. So can you?
Yeah. So
them?
almost Warangal is one of the places historically known for Kakatiya rulers. We have had Thousand Pillars Temple, which is located in Hanamkonda region, and then we have Warangal Fort, and then we have Bhadrakali Temple. These are within the city, but we have adjacent to Warangal many historic places as well. Ramappa Temple, which is a scenic lake, and we have Etur Nagaram, which is again a forest area. So very interesting locations around Warangal, which as growing up, we have had the opportunities to visit them and try and learn. It's exciting, it's a nice place to be in Warangal, yeah.
I think Ramappa Temple has been awarded the UNESCO Heritage Site also, I think. And
Yeah.
recently I visited it. It's a wonderful kind of a temple that preserves ancient architecture.
Definitely, in terms of architecture, also I think there is some unique technology used to make these bricks or stones which float in the water. I think there's some technological innovations as well in how our ancestors, our forefathers used technology in a way to construct these sort of beautiful constructions, architectural designs.
So you did your college there, undergrad, and then where did you do your masters?
So I was interested because as I was saying, Warangal shaped my ideas about what I should be doing. So after my graduation, I was trying to see how best to pursue my ideas around working for the benefit of humanity, more in terms of on the ideas of equity, equality, social justice, etc. And one of the uh, I wanted to pursue both science and also studying the society as one of my ideas for to bring forward my ideas. So that's where I found that anthropology and sociology are interesting subjects, along with my interest in zoology, which I was very interested in. So I got into zoology in Kakatiya University and also sociology and anthropology in University of Hyderabad. I got to know about the University of Hyderabad through one of my seniors in the college. So they said, till then we didn't know, though we were neighboring, living close by to Hyderabad and visiting, we never knew there was something called Hyderabad Central University. It was largely Usmania or Kakatiya University were more popular those days or more known. So when I discovered that there is a discipline called anthropology and also something called sociology, I thought, let me give it a try. I also wanted to go and explore in other universities such as JNU, but finally I decided to pursue anthropology in University of Hyderabad. So that's how I landed in the University of Hyderabad in 1995 to pursue my masters in anthropology.
So this was 1995, where the University of Hyderabad, or the Central University of Hyderabad, I believe was kind of known, even being outside Hyderabad. Perhaps like it was way out of the central city also. So how was life in the university? It's a very large campus, or perhaps like one of the largest campuses. So if you can describe life in the university, I'm assuming you lived here also. I mean, or you lived in and around the university.
Yeah, it was like an island in itself. University of Hyderabad was far thrown away from the center of the city. We had one or two buses plying between the university and the city center habits via Mehdipatnam. So initially it was uh, very, in a sense, the sense of farness was, it was something very evident when I got into the university, that we had to travel by a bus for about an hour and more from the city center to reach via a very small road, which was a single road without much of humans, being sighted after Mehendipatnam. So it was uh, an interesting experience, but it actually was something which is amazing as a campus. Massive campus, lush greenery, lot of wilderness plants, and lot of people across from across the country. This being a central university attracts people from across the states in the country. So we had a good set of diverse set of people from across the states, and having been disconnect from the city with very less opportunities to go to city, so we had to stay in the hostel. It was a residential. Initially I didn't get a hostel in the campus, so I used to travel by the university bus or RTC bus from the city, where I used to stay with my relatives. So it was an amazing experience of being a part of a university which was very far, and but it has its own sort of life which is distinct from what I have grown up being in Warangal or in Hyderabad. So that was very interesting times where less mobility and
Central universities, the life inside is not just active life, but also, as people say, an activist life. So how was your life in Central University of Hyderabad studying anthropology?
that's a good question in terms of how these universities are supposed to be and how they should, what their role is. So that's actually well put when you said active and
Activist.
activists. So when I came in, I was already, as I said, Warangal shaped the ideas of social justice. Talking about how a place shapes us. So definitely, I was inspired by the place I was born, and then it actually Hyderabad Central University was an extension. It gave me an opportunity to try and sharpen my ideas around what could be social justice, what could be definitely trying to bring in rights perspectives and talking about marginalized communities, etc. So university then was a potential site for sharpening your thinking about society ideologically. So I was already ideologically oriented while being in Warangal. So Hyderabad Central University definitely, gave me an opportunity. I was very active in Students' Union politics since my master's days. I was a part of election commission, a member of election commission. University has a history of conducting students' union elections. So I was in my master's first year itself. I was part of this election commission, and next in the master's end, I think I was chief election commissioner, and then eventually, while I was progressing with anthropology and trying registered for my PhD, and also I served as a student union president in 1999, where definitely the the active sort of a context in the University of Hyderabad helped me be the activist I wanted and try and do something for the society.
During masters, people do their research and thesis. So, what was your thesis about, or what are you trying to focus as part of your research during your masters?
So my master's degree, anthropology has a unique element of training students through fieldwork. It essentially trains us in ethnography, trying to study the people and their cultures by living with them and writing about it. So my fieldwork as a part of my master's degree was in among the Konda Reddys. So I was trying to understand the various social institutions among Konda Reddys in East Godavari district. We lived there as a class, went there and stayed there in Maredmelli village, interior tribal village among Konda Reddys. Stayed there for about 28 days and then tried to understand their life, being part of their life. And that was one of the important sort of a milestone in my career, which shaped my thinking of how actually the lived realities of these most marginalized communities shape their life, including health and well-being. So after my master's, I did my MPhil degree. Apart from working with Konda Reddys, I worked with...
And this MPhil, when did you start? Which year?
Masters was 95, 97, and immediately 98 I started my MPhil program in anthropology, focusing on medical anthropology. So that's where I started to look at how, because I was inspired by certain studies in anthropology which started talking about how culture shapes health, and that's how I started to think about what should I be looking at as a research area, and that's how medical anthropology attracted my interest, and that's how I took medical anthropology as a area under the supervision of Professor B.V. Sharma, who was one of the anthropologists who was started to work on interlinking anthropology and health through medical anthropology.
A lot of career talk, but a little bit personal information if you can. You're being a student at University of Hyderabad, and being a student you have to go around for sure. So can you please tell us about your first bike, maybe first car, and your interests, which cuisine interests you, I mean any foods that are something that you like perhaps going around?
Yeah, personally, I always had a fascination towards technology, including bikes and also cars. But university those days, it was only walking on foot, because being a leader, we had to be around meeting people, talking. At the most, bicycling. But I had an opportunity to use two-wheelers such as Suzuki, which I started using, Enfield, Bullet, which was one of the iconic vehicles then, and also Kinetic, Honda, Activa. So whatever comes my way, I had to pick and choose. But definitely, technology interests me, and in terms of how, my first car when I bought was Tata Indigo. I wanted something which is a longish car with which was a sedan, and then Tata introduced then the Indigo. It was post liberalization. Marutis were phased out, and you had these newer cars coming in.
And this was in which year?
99, no, it was, I think, later. I think I bought a bike which was scooter, because we thought having scooter was useful to have. So Honda Activa was my first scooter, and then 90, I think a little later, 2002 or 3, when I was finishing my university and started working for an NGO, then I bought my car with my savings. So that was interesting times those days.
A little bit more personal. I believe you also met your wife at the university.
Yeah, wife and I both studied in the University of Hyderabad. Soumya Dechama is my wife, and she is currently working as a professor in comparative literature in the University of Hyderabad itself. So she was pursuing her master's in English when I first met her in the sports complex. But essentially, we got to know each other while she was campaigning for me in my elections in 1999, while I was contesting for my presidentship in the Students' Union in the University of Hyderabad. And then things moved on, and we ended up being together.
So you won the election?
Yeah, I won the election.
And the campaigner also.
Yeah, and the campaigner as well. So it was a double bonanza, election and a life partner from there. So
that's an incentive to contest in elections, I guess.
Definitely, you make people, friends, and relations build on. Yeah.
So your favorite cuisine or your favorite dish?
Definitely Hyderabadi sort of cuisine. Biryani is my favorite dish. I love Hyderabadi biryani. So that's how uh, I'm interested in cooking and cuisine. So lots of other cuisine as well. But definitely my favorite food, hands down, is biryani.
I think that will resonate with a lot of Hyderabadis, I guess. Moving to slightly on the professional track back again. The purpose of this interview is that we are actually starting India's first school of digital health at Mallaredi Vishwavidyapith, and the country as such is undergoing a digital transformation in healthcare. And the way the transformation should actually happen is not something that what happens on paper or on analog should be as it is converted into a digital platform. But rather, we need to start rethinking the way healthcare is actually delivered and see it from different perspectives. As you mentioned, we need to live through the experience in the eyes of the patients, in the eyes of the healthcare personnel, and then it gives you a better way or a better idea on how to redesign healthcare also. So, in your opinion, how do you think digital health will be? I mean, this is not a very specific question, but if you can, extend your imagination and say, okay, this is my vision of digital health. We would want to know, without any kind of a boundaries, how do people pursue digital health as such?
Thank you, and I think I should congratulate you and Mallaredi Vishwavidyapith for initiating the first school of digital public health or digital health. And it's something which I imagine digital health as having a vast potential of providing equitable and quality care to the people to the maximum extent. Because as I was telling you, my interest in health, was while studying the tribal population. So one of the major challenges, if you look at in India, is the inequity in terms of access initially to begin with to any sorts of care, access to qualified professionals, access to medicines, access to, and then comes the quality of care. It is certainly a challenge to provide quality care, and that's where digital health, as I see, has a vast potential to cover a majority of the underserved population and far too rich populations. So I feel that is a good starting point for me which who have studied the most vulnerable people, and access is a primary reason why I thought, I was thinking of potential of digital health.
So the broad idea is digital health can improve the access, and access is very critical and a key challenge for healthcare, public health, and a lot of services also. Again, in your opinion, are there more challenges in healthcare as such?
Definitely, in terms of healthcare has been a sort of an important push by the government of India across as one of the welfare measures as well. For example, national health missions, or you have had vertical programs such as tuberculosis control programs, AIDS control programs, or maternal child health programs, or many of these. Healthcare has been a high on agenda of government programs, and apart from connectivity in terms of quality and equitable possibilities of equitable care, one of the important things I see is healthcare, digital health can be a leveler is in terms of diagnostics, for example. So how do you, as you rightly said, most of these sort of programs have a manual way of documenting data. But if you really look at the role of digital health, if you take the case of tuberculosis, for example, how do you really, tuberculosis is equally a social disease and a cultural disease, along with all these factors shape the disease in the communities what we're talking. How do you really connect these dots? And digital technology, for example, the how do you take the technology to the doorstep of people to try and understand the social, cultural, economic, ecological factors that shape a disease?
It's very interesting that you mentioned about the patient's perspective on what they actually want, and also mentioned about taking healthcare closer and closer to people through a digital platform, which in some ways addresses the issue of access. But in another way, it kind of opens up a new area where usually, or in a traditional format, patients come to a clinic or a hospital. It's fairly set in a very standard way. But when you actually go to a person's home, the entire ecosystem is very different. And at least in our opinion, the same kind of care that we are providing cannot be simply transported to a different location. So if you want to understand the ecosystem from the patient's perspective, from the location perspective, how do we kind of get all this information? Theoretically, how do we kind of do a study, do a research, and then get all this information that we can perhaps like even document in a paper, and then see how do we include this into the service. So there's a fairly what you call I would say very established theory on how to document the location ecosystem. If you can please talk about it, I think that would be really helpful.
Thank you. In terms of the potential of using, for example, I'll talk about anthropology, and then how anthropology means studying human beings in a holistic way, and then you have very specific approaches such as ethnography, qualitative research methods, etc., being largely used in anthropology traditionally. And when you're talking about understanding the healthcare from the point of view of patients, in a modern parlance, you call it as user-centricness. So if you try and look at how you talk about the people who are the beneficiaries, last mile connect in the healthcare connect is the people who are the beneficiaries or the users of these facilities. And there is a massive transition in the way that we are calling it epidemiological transition in Indian context. You have, due to various public health interventions, infectious diseases are slightly, under control many places, and definitely non-communicable chronic conditions are increasing. So the interface between the people, patients, and health system now it's changing dynamically. So are the relations between the patients and the providers. So therefore, if you really wanted to understand this larger ecosystem of how and what are shaping the interface between the users and the healthcare system, you need to have to bring out very subjective experiences of the people who are using. And for that, anthropology as a approach, as a discipline, and also ethnography and qualitative research as research methods would help us to understand the people involved in the healthcare transaction better, and then bring those subjective experiences, beliefs, practices, values which are shaping this healthcare to the forefront, so that we are talking about creating services which are human centric in nature. Therefore, try and design which are services or healthcare programs or healthcare interventions which are more focused on to the users, from a human centric sort of dimensions. And
Can you mention a few methods and maybe briefly explain how they can actually be done on the field, maybe in a person's home?
Definitely, in terms of the USP of anthropology has always been ethnography. Ethnography, if you look at the etymology of the word ethnography, ethnos means people and culture, and then you're talking graphy is writing. So one way is a conventional way of using anthropological ethnographic approach is field work. You go to the people, you stay with them for some time, and then you try and document their culture in total, because as I was describing, health is shaped by larger social, cultural, and ecological factors. So as an approach, ethnography is an interesting approach which we use in medical anthropology to understanding people's health and illness. But methods such as focus group discussions, ethnographic interviews, in-depth interviews, and participant observations, these could be the methods which can definitely help in understanding the people and their perspectives better.
Along with healthcare becoming digital, I think some of these methods are also slowly transitioning off into digital data collection.
Yeah, that's interesting, because now digital anthropology has come up in a big way. For example, during COVID times, we have seen how infodemics is COVID, as was known as pandemic, was also known as an infodemic. So how social media, for example, had played a large role in propagating misinformation, while there was a lack of clear scientific evidence about the cause, the impact, and vaccines, etc. So digital anthropology has come up in a big way, where there is an integration of the ideas of digital potential of digital tools and digital approaches being used in anthropology, and then how there could be an interface between the technology and people and culture.
We'll go back to your career pathway from MPhil and
Yeah.
what next, please?
So I was after my MPhil, I wanted to pursue medical anthropology further, and therefore I wanted to continue my focus on the indigenous communities, Adivasis or tribals as they're known. So I was pursuing a PhD topic on tuberculosis among tribals, because those days the incidence of TB among tribals, especially Chenchus, was reported high. So that's where I wanted to do a comparative analysis of the Chenchus, the Yerukalas, and Lambadis, and then trying to look at the cultural and social and economic status of these tribes. Chenchus were in Nalamala forest, Lambadas were in plains, and Yerukalas also were in plains. So I was trying to look at the comparison. That's where I started in 1999. But due to some reasons, I had to discontinue, because there was access issues those were the days where the Nallamala forest was conflict ridden between the Maoists and the police, and there were some issues where my fieldwork was in these sensitive regions. So therefore, I had to pause a while because I did not have access to these field areas. So that's where I got active in the students' union politics. But eventually, when I realized that after my first 1.5 years of PhD, that's when I also had an opportunity for working for an organization called International Center for Research on Women. So they were looking for anthropologists who trained in medical anthropology to look at how intimate partner violence and HIV/AIDS, there is intersection between the social cultural context and HIV/AIDS in Andhra Pradesh then. So while I could not get back to my PhD fieldwork, I got an opportunity to work for an organization, and it was paying well. But also, I was more than the anything else. It was matching with my ideas around how we should extend the university activist role into the communities, and then work for non-governmental organizations, especially on issues around equity, empathy, etc. So that's how it caught my attention. It was an opportunity where I started to work for NGOs in 2000, 2001, between those days. And then I had to discontinue my PhD and then continue for about 4 years to work with International Center for Research on Women on this.
And from there to PHFI, how did your career carry on?
Well, there was another pit stop at Clinton Foundation, because after 4 years, most of these non-governmental organizations, that project was funded by Gates Foundation, and it was on, as I said, intimate partner violence with truckers, trucker spouses, and sex workers. And while I was continuing I was very keen to continue with the International Center for Research on Women. There was a challenge of funding, and I was looking for jobs after while the project was closing down. And Clinton Foundation was working on something called Bala Sahayoga program. They were focusing on children living with HIV/AIDS, and I saw it as another opportunity to try and bring in my ideas on working for the people and the communities, and that gave me an opportunity to segue into management as well, because bringing research and trying to integrate into program management was something which was interesting for me, because that Bala Sahayoga program was working in collaboration with a couple of other NGOs called Family Health International, FHI, and CARE. Within 1 year or so, I then moved into pediatric initiative, where again, interestingly, there's a lot of technology was being used, where, for example, first time the dry blood spot test, which was supposed to be an innovation in trying to test the children who are neonates for HIV/AIDS, was introduced. And similarly, health records, digitalization was being used as a programmatic tool. So Clinton Foundation was one pit stop which also exposed me my ideas of. By the way, I also trained as a program management in University of Hyderabad, because I was trying to skill up in terms of what could be other skills in addition to anthropology which I could improve on. So I had program management as a PG diploma while studying PhD. So this was a helpful sort of stint at Clinton Foundation, nearly 1.5 years. And
now slowly I think you found a way to broadly continue learning as what you learned in the masters, and then also kind of expand on how to implement the learning for the society. I think that's a great way to connect studies with career, but also to the community also. And slowly it kind of progressed where I'm assuming the project that you worked at Clinton Foundation was also a multi-state one. I think
Yeah.
it was also a national project, I guess.
Yeah, the pediatric initiative was a national initiative where Clinton Health Access Initiative is called CHAI. So they essentially were focusing on provision of care for the people, children living with HIV/AIDS and their families. That was one part of it, and also strengthening the capacities of the healthcare personnel on emerging technologies such as dry blood spot test. And it also had was working very closely with Government of India, National AIDS Control Program on NACO, as it was called. So they were providing technical support because I think Chai was also a pioneer in trying to push for generic drugs. They were helping the government procure generic drugs for HIV/AIDS, which was very low cost, and they were exporting them to other African nations because HIV/AIDS drugs were very expensive, which were manufactured in developed nations. So, in that sense, trying to straddle multiple roles, trying to facilitate community sort of interventions, capacity building programs for healthcare providers, including doctors and healthcare staff, laboratory attendants, and also trying to be part of the program where they are integrating the procurement of generic drugs and exporting. So it was an interesting experience working across the country.
And then next you joined PHFI?
Yeah. So while I was at Clinton Foundation, I realized that while I was doing these capacity building initiatives, I realized that there is a need for capacity building, especially in terms of community health or public health, as we call it. How do you really encourage the human resources to skill up as and when there is technological interventions? Because healthcare, as you providers, as you know, are not proportionate to the population. They are heavily under stress. There is a lot of work burden on them. But definitely, I saw a potential of how capacity building will help in improving the quality of care. So that's where I happened to know about Public Health Foundation of India, which was started by Professor Srinath Reddy, who was trying to push the idea of public health across the various disciplines. And they have propagated the idea that public health should be interdisciplinary. So that's where I had known about it, and I took it to immediate liking to this idea of interdisciplinary context of public health, where there is a potential of various disciplines such as anthropology, sociology, or engineering, or management, or behavioral scientists, all coming together to shape the public health of people. So that's where I took a sort of an opportunity. I saw that as an opportunity, and I also wanted to get back to academia, pursue my. I left my PhD because of inability to continue field work, and I was working. So therefore,
So when did you join?
I joined Public Health Foundation of India in 2008. I think during the same time where you joined. Around 2008, is that when you joined?
Yeah, I also joined in 2008, I think September.
Yeah, I think immediately after you joined, you had to leave for your PhD in Japan.
Yes,
I think
right.
that's where I think I was there, and I was I joined PHFI with a master's and MPhil degree with about 10 years of community-based experience. But having joined PHFI, I realized that you need a doctorate degree, to have a career in public health, to teaching career. That's where I got an opportunity through PHFI in welcome-funded PhD program. It's called Future Faculty Initiative. One of the important initiatives of PHFI was to encourage young faculty members to be trained in other countries as a part of public health training. So I got an opportunity. I was selected for Wellcome Trust funded PHFI program for future faculty members, and then went to University College London to pursue my PhD there.
I think PHFI or Public Health Foundation of India was a grand idea, spearheaded by Professor Reddy, of course, and it brought together a lot of people like us who were thinking about multidisciplinary studies and also bringing together academics, research, practice all together in one platform. Plus, it also provided a fantastic career, not just growth, maybe an acceleration platform, where with all these ideas and with the potential to make a great change for the country, I think it was a wonderful idea. Or perhaps I keep repeating that PHFI or Public Health Foundation of India was a grand idea. So I also joined PHFI in 2008 September and took a long leave to pursue my PhD. And it also, as you rightly mentioned, had a future faculty program where almost, I think, 50 to 70, I don't know the exact number, but about 50 to 70 people were supported to pursue PhDs at some of the top institutions in the world. Well, I was not part of the program, but I also kind of did PhD in a similar time frame. So, what were your PhD focused on? And again, at PHFI, we are part of several projects. So, if you can talk about your PhD focus or your PhD topic and the several projects that you are actually part of at PHFI, and also the academic role that you played at PHFI, I think that would be great for the viewers to hear.
Thank you. In terms of PHFI, as I said, it is a grand idea and an ambitious one. It was, I think, my pull towards it was because it was demystifying this public health from a very biomedical view to bring in the interdisciplinarity, as you rightly said. We saw the potential of bringing all of us from various backgrounds to work on making people's health better. So having said that, it was also an idea which was a bit, challenging to take it forward because it involved having a lot of people sensitized to the idea of interdisciplinarity, and that's where the Future Faculty Initiative was aimed at, to bring in that sort of exposure to most of the young, leaders in public health to be trained abroad to broaden their perspectives, including the skills and also more importantly the interdisciplinarity in terms of research and programs. So my PhD project was on suicides among farmers. I was focusing on bringing in anthropological perspectives and cultural psychiatry perspectives to understand suicides among the farmers, who are one of the most, the high number of suicides reported among cotton farmers. So because of my earlier initiation into the issues of equitable sort of a care, mental health has been a major sort of a challenge. Even now we don't have much of a mental health care, accessibility to mental health care. So I was trying to look at how the mental health status is shaped by the social and cultural context, such as humiliation, etc., among the farmers, and then how people are driven to die by suicide was my focus. And then how do we really understand this from anthropological perspectives to come up with better solutions, such as designing mental health sort of interventions more focused towards farmers, such as marginalized communities such as farmers. So that was my PhD focus, and I did my PhD from University College London, as I said. But while at PHFI, there are a lot of projects I was involved. One of the projects which again brought all of us together, I remember, was Trump, which was an interdisciplinary.
So now you can say the word Trump.
Yeah.
With no resistance. There was a brief time where we were not supposed to use the word Trump.
Trump, yeah.
Now it's okay.
Yeah, because he's back in power, though it doesn't connect to the person we are talking about.
Yeah.
But I think Trump was more about how technology was has the potential. It was an important idea which we had collaborators from Newcastle, University of Aberdeen, and Public Health Foundation of India, where IIPH Hyderabad was part of it. So some of us, including you, myself, and Dr. Raghu, etc., we were all part of this. Sitama, I remember. So we were trying to understand how technology could be used to for self-management of conditions such as diabetes and depression, because around the time UK, the researchers were using technology and then trying to have a comparison between UK and India to try and understand how could technology could be used in difficult to reach populations. So for that project, I remember working in Guntur region to look at diabetes and also depression, and then how mobiles are not, I think mHealth was catching up by then, but also interactive voice radio messages were also being used. So we tried to test these sort of test case of using interactive voice radios for communicating with the patients through radio messages, and also mobile health reminders, because when we realized that the most of the rural population were using the mobile phones, which was the button mobile phones, were replaced as a family phones. It was not that each person has access to one mobile phone, but it was more used as a family phone. So we are trying to understand the journey of technology there in terms of how it could be used for self-management. It was ahead of its times, I would say, but also it also helped me understand that technological fix is not the one only way of doing it. We have to also have to increase the capacities of the people or healthcare position, also structurally making better facilities available for people.
There's usually a saying that when technology works, immediately it's all about human requirements. The moment it works, people forget that there's actually technology, and then it's all about usability, it's all about the relevance, it's all about how much it actually benefits. But it's also very interesting to quickly trace back and see how your ideals of equity, how the ideas of multidisciplinarity, which in some ways is still a challenge, but there's been a substantial improvement in the way healthcare reaches people through digital platforms. Today, we don't see multidisciplinary teams as an exception. In fact, more and more they are actually looking very normal. But in the last 10, 20 years, it was very new to a point now where things are fairly looking normal. Of course, there is still a long way to go forward. But I think we have reached this so-called inflection point where things could exponentially become better. Even issues like mental health. I was associated with one of the apps which provide the what you call intelligent response to chats. It's called as your best friend at 3 a.m. And even with regard to diabetes, now we are witnessing this continuous glucose monitor. Again, it's a digital platform where you are able to collect all those things. And combining with a smartwatch, people are now saying that they are able to control diabetes. Some claim diabetes reversal also. But we are living through these times where we can actually see this transition. And but it also becomes a challenge where the curriculum also needs to keep up with these changes. It becomes wonderful to be part of this journey and also to see all these changes. But how do we include this into the curriculum? But before we go there, if you can also please tell about your period as MPH coordinator or the Masters in Public Health program at IIPS that you are coordinating. I think that would be a wonderful start to get back to the academics, I guess.
Yeah, I think the question you asked about how technology could be, equitable, helpful in this, trying to make it more equalizer. I'd also like to give an example of one of the other projects called, which I was, funded for. through Public Health Research Initiative while at PHFI. It was called Technology for Inclusive Care. So essentially, when you're talking about technology, as you rightly said, it has a potential to scale. But I think initially we have to test the case while we are working in the community. So to give you the example of technology for inclusive care, the idea was to work in Adilabad district in interior tribal places to try and see what we assume, for example, the glucometer, the sphygmomanometer, blood BP machine, or even the digital device to test hemoglobin levels at the doorstep. These what we are talking as a routine healthcare devices or even wearables for that matter, how they would actually be available or accessible in the interior tribal places was the idea. So we tried to do something very simple to try and put all of these machines into one kit and then train the healthcare workers like ASHAs and ANMs on these ideas that we can use these simple pre-existing technology, train them well, and then we used a very simple mechanism of using these digital printers, handheld printers, so that the ANMs or ASHAs, while visiting the people, can enter the readings on hemoglobin or blood pressure or blood sugar, and then that could be transferred into an Excel sheet for facilitating a continuous monitoring. So idea was simple, but I think when you want to see whether an idea to scale would function, we need to conduct these sort of pilot exercises in the community and test it. So that is where the potential of scale could be pilot tested using so that project was useful for me. But those things, as you rightly said, I was the coordinator for public health program, masters in public health program in IIPH Hyderabad, and also I contributed to designing of public health sort of curriculum both in University of Hyderabad as well, when we started collaborating with the University of Hyderabad School of Medical Sciences to bring in public health as a program here. So while I was
maybe one more addition. I think we were also part of the MPH and also Health Informatics Board of Studies
Yes.
at Apollo University also.
Thanks. So I think, were part of this curriculum committee in Apollo University, trying to introduce both public health and health informatics. So I think one of the important learnings for me in my learning process of working in the communities and academia has been that effective training through designing good curriculum will ensure there is the required skills for the students, and also in terms of their potential to contribute in an effective way while they are ready for their jobs. So I feel there is a lot of potential for the designing curriculum these days. We have as I said, access to a lot of international exposure helped us to try and design very current context, the curriculum based on the current needs, and also a bit futuristic. I think, we all have to be aspirational, because we need to try and skill the students who are coming in more futuristic technologies. But having the basic, training in empathy, or embeddedness in the local socio-cultural context is important. So that's where, as an MPH coordinator, my sort of emphasis has always been to try and ensure that there is a equitable mix of disciplines, including social behavioral sciences, health economics, digital health, epidemiology, biostatistics, and environmental occupational health. So our idea of public health was truly interdisciplinary, having these modules for being part of the curriculum. And also, when we did this health informatics program also, I remember we having a lot of discussion on how do you make these students more, skilled through hands-on projects, live projects. So I think we had integrated these ideas of good theoretical grounding, but at the same time on the job, sort of on the ground learning for these students through tackling live sort of problems as test cases. So that I think that was one of the ideas which I also believed in firmly, that helped in shaping the curriculum of various public health programs.
I believe career-wise, you also did a full circle by rejoining University of Hyderabad, and you are also managing the anthropology programs now. But to kind of retrace our steps also, as I mentioned, we are starting up the School of Digital Health at Mallaredi Vishwavidyapit. And all the points that you mentioned are very valuable to us, simply because, again, as I mentioned, multidisciplinary is an idea, but for now it looks more and more like an implementable idea, whereas long ago people were teaching everything in silos. Some institutes still do that, but thankfully we have been through this experience for almost 20-25 years, and multidisciplinary feels like the normal way to approach any kind of a challenge or a problem. And also the fact that this project-based learning, which again perhaps I have to thank PHFI, because that was one place where we had an opportunity to be part of several projects, also write up several grants, and integrate the learnings into the curriculum. So this is all some of the things that we would be we will be looking forward to implement into the School of Digital Health. Is there any specific areas that you would want to add that can be part of the curriculum?
Well, I think that's a good point you made in terms of the journey of interdisciplinarity and the potential further. Because my journey back to anthropology was also, shaped by my interest in trying to contribute the discipline of anthropology, and then try and integrate my learnings from the field to try and improve the certain ideas within anthropology, so that it can help us contribute in shaping public health research better. So in that process, currently I'm trying to pursue, I'm offering 3-4 papers. One is medical anthropology, which I have trained in. The other one is ethnography. I'm offering a course in ethnography, module in ethnography. And then I'm also introducing a new course on multi-species ethnography, trying to push the ideas of anthropocentrism and trying to locate the larger ecosystem as a context for sustainability. And also I'm looking at practicing anthropologies. The reason why I listed out these courses is in terms of how we can ensure that there is a dynamic sort of a context. A curriculum should be dynamic.
I think you mentioned a lot of things that we could also include in our curriculum. And thanks a lot for introducing all these new ideas. But it has been a wonderful journey starting in Warangal with the ideas of equity and then progressing till here. It's been great working with you at PHFI and also continuing our relationship at University of Hyderabad, and hope this will actually provide us with a lot of opportunities for further collaboration in the areas of digital health. Looking forward to working with you continuously and perhaps take our journey even further.
Thank you, Dr. Suresh. It's a pleasure talking to you, and it has helped me to retrace a lot of things back in my life and a journey into public health with friends like you. I definitely hope that we'll continue to collaborate, and I look forward to be associated with your digital public health school in Mallaredi Vishwavidyapit, and I wish you all the very best for this upcoming program and also future ahead. Thank you so much.
Well, thank you very much.